Well, good evening, everybody. I have 8:01, which means it's time to begin. Welcome to this webinar. It is the first part of a three-part webinar series that'll be continued in, I believe, September and February. We're going to spend the next hour discussing accelerated orthodontic techniques using micro-osteoperforations. And basically, we're going to walk you through the sequence of events that would help you to include this as part of the orthodontic technique. And I have been now using the micro-osteoperforation technique for about 5.5 years. But to give you some of my credentials or history, I'm not employed by a dental company. I don't own any stock or securities or interest in a dental company. And none of my family, immediate or extended, does, so I have none of that interest there. I have consulted or evaluated products for the following companies: Propel Orthodontics, Align Technology, 3M SB Ortho Organizers, which is now owned by Henry Schein, so maybe we should throw Henry Schein in there just to be safe. So there you have it. The idea behind micro-osteoperforation dates back to, or has its roots, early foundation in what's known as Wilcodontics. Dr. Wilco from Erie, Pennsylvania, used to provide periodontal osseous surgery to his patients in orthodontics, and at the time when they were doing that, there was a noticeable increase in the speed of tooth movement. And so what we learned early on was that if you injure the bone, which means produce an inflammatory reaction or a lot of inflammation, the cytokine production is the key ingredient, and as the cytokine level goes up, the rate of bone remodeling increases and the bone density decreases. So what in effect you're doing is you're making the bone softer, and with the rate of bone remodeling increasing and the softness of the bone, you combine the two, and what you get is rapid tooth movement. So the goal isn't to just keep applying more force to the teeth. We all know well what happens there. That causes lots of trouble for all of us. So the goal is to get the rate of bone remodeling to increase, and the way you do that is by introducing more cytokine. It's the main ingredient. Of all the inflammatory markers, the cytokine presence is the best indicator of what the rate of bone remodeling will be. So our goal is to elevate the cytokine production in our alveolus, and that what that'll in turn do is remodel the bone faster so the teeth move faster. So we're looking for acceleration. So orthodontics, and a recent survey or a statistical paper was produced that showed more and more adults are looking for orthodontics. We're going to be focusing on adult orthodontics because we're dealing with a micro-osteoperforation technique. This technique I offer to patients who are 17 and above, and the age below 17, I have not utilized it yet on anybody under the age of 17. So basically, micro-osteoperforation is what the word says: small bone perforation. And so we're going to make a little wound. You know, perforating the bone is wounding the bone, and wounding the bone generates the inflammatory response to heal it. So every time you wound the bone, the body responds by wanting to heal it, and the elevation of the inflammatory markers helps the bone heal. Bone healing, bone remodeling, those are two similar things. So when we have an orthodontic process in place, which could be anything from braces to clear aligners to removable appliances, whatever you might want to describe them as, when you're introducing micro-osteoperforation, it gives you an advantage on any level regardless of your orthodontic technique. And once a patient understands that orthodontics are an option for them, typically the next question or avenue of, let's say, questioning a patient would want to know about is the speed, or how long is it going to take. Orthodontics certainly takes some time. It's not the turnaround that a set of veneers might be, or some restorative dentistry. So we have to have some patience with orthodontics. And in today's microwave society, any advantage you could have to speed up the process would be great, as long as it's done in a healthy manner. And micro-osteoperforation is a way to induce faster tooth movement in a healthy and comfortable manner. So the research dates back quite some time. I know I mentioned the early roots are with Dr. Wilco and Wilcodontics, and doing periodontal osseous surgery from molar to molar, and full flaps with all kinds of wounding going on, because that's basically what that is. And with that and all the inflammatory response, you get a lot of rapid tooth movement. So basically it is the rate of bone remodeling that determines our speed of tooth movement. These are not new principles, so they've been around for quite some time. And the way to have an effect on the speed at which a case can be treated is to have an effect on the rate that the bone remodels. That's our goal. So we do have decades of research. that have been refined into a simple technique here. So what started out as a Orthodontics, a big heavy periodontal osseous surgery, which can benefit patients who need periodontal osseous surgery as well as orthodontics. That's a wonderful choice for them. But when you don't require or need periodontal osseous surgery as part of your treatment planning, then using micro-osteoperforations becomes a simple, comfortable, and easy way to provide some rapid tooth movement. All right, so basically we're taking that dense bone. The patient walks in to be treated, and you know how those teeth feel. If we're dealing with normal, healthy alveolar structure, the teeth are rigid. The patients that we're working on don't really have an initial mobility of their teeth outside of normal, so these are rigid, fixed teeth. And basically what happens there is we're, by wounding the bone, softening the bone, and making that bone remodel faster. So we introduce a greater level of orthodontic mobility to the area while we're remodeling that bone to move the teeth at a faster pace. So basically what we're doing here is looking at increasing the rate of the tooth movement 2 to 3-fold. So if we include micro-osteoperforation as a technique, we would expect to have, at average, a reduction of half of the treatment time. And so in the early days, which early days for me are about 5.5 years ago, we began providing the micro-osteoperforation technique to clear aligner patients. And what we were doing in the early stages was having them walk their way down from that 14-day change. The clear aligner recipe is the 2-week interval, and wearing one aligner for 2 weeks at a time was the path. When we first began, we started with 12 days. We were wearing the aligners for 12 days. Then we went to 11, then 10, then 9, then 8, then 7. And we've worked down throughout the next, let's say, 3 to 4 years to kind of hone a process where we can have a very predictable rate of tooth movement. And I have a chart at the end of this presentation that shows what it would be a breakdown for mild to moderate to severe orthodontic conditions and how many rounds of micro-osteoperforation might be needed to provide what type of tooth movement rate and what type of aligner change. So we'll definitely get into some of the differences between mild, moderate, and severe types of cases that we've treated over the years. So the clinical trials were done through NYU, and basically, obviously a device is used, which we're going to get introduced to in a moment, to create micro-osteoperforations. And that clinical trial showed a 62% reduction in treatment time, which is very nice. My experience is anywhere from 50 to about 60% reduction in treatment time. The early stages where we were beginning to test, we were getting 30 to 40%. Once we realized what it was capable of doing, it's a standard now to have at least 50% of the case time removed. All right, so the NYU clinical study was significant in that it demonstrated fantastic tooth movement, but also in the line of bodily movement or translation type movements, not just tipping. So also part of the research was to show the patient comfort, and it has been my experience and being consistent with the NYU study that the patients that we treat with the micro-osteoperforations have a more comfortable orthodontic process than the patients we don't. There's an amount of soreness or tightness or strain or pressure that you feel from any orthodontic process. And the idea behind the micro-osteoperforation, if you produce more of the inflammatory markers and you soften up that bone and you create better bone remodeling, you get better tooth movement. It's faster, but another significant result of the clinical trials and my experience has been that the comfort level is better. And so amazing, we're going to move the teeth faster and we're going to do it more comfortably. So there are different ways to offer accelerated orthodontics, and we were mentioning before the corticotomy technique. That's the old Orthodontic technique, and you know there are patients who can benefit from a comprehensive treatment plan of having an orthodontic process along with their periodontal and osseous surgical techniques. And for let's say older patients that may have more involvement of the periodontal structures, significant amounts of gum and bone loss requiring those procedures, there you have a slight advantage. But it is the most invasive technique of the choices in accelerated orthodontics, and that technique does involve a fair amount of recovery, a higher cost, a little more time involved in the treatment. So there are pros and cons to all of these. A slightly less invasive procedure would be the piezo surgery type. So still invasive, still takes some time, still has a little higher cost to a patient. Again, pros and cons to these types of procedures, but the micro-osteoperforation tends to be the most comfortable, easily delivered, It's very incredible low cost compared to the other procedures, and so in it being efficient on so many levels, it's a wonderful process to be able to deliver in a short amount of time. So we've got something that's efficient and comfortable for a patient to have at a low cost, so it doesn't really have an effect on the overall treatment plan. When you're dealing with an orthodontic case that has a significant fee, you have a micro-osteoperforation technique that might add a little bit to that fee, but there's nothing wrong with that. If you're having an expense for the micro-osteoperforation technique, you do gain in two directions. One direction is that you have a fee for the service, okay? Having a fee for the service is appropriate. You're offering a service to the patient, you're going to spend time delivering it, even though it's a small amount of time, and you're going to use a device that has a cost. So we have a fee associated with the procedure. The secondary effect of the micro-osteoperforation technique is that you're going to cut your treatment time in half or better, and then you have the increased profitability of reducing your chair time. So the advantage of the micro-osteoperforation is that, or my advantage has been, I see more profit from that procedure in the chair time I save by cutting 50% of the treatment out than I do from actually charging for the procedure to do it in my chair. But meanwhile, you're entitled to both. So now the micro-osteoperforation devices, we have three here. Basically what it is the early days are on the left side of the screen. Now the early days, the appliance was a single use, a disposable appliance that had a clear covered sheath, a depth gauge, an indicator light, and a way to set the millimeters by this little handle. The white bar could be spun to 0 all the way to 7 millimeters for depth. And then as you would kind of rotate clockwise in twisting motion like a screwdriver, placing a screw, that motion would deliver the depth, and then the light would go off. You'd see a red light go off to deliver your distance, and you'd know, oh, I'm at 3 millimeters or 4 millimeters. So the device was disposable. That cutting edge was very sharp. It would be able to deliver all of the micro-osteoperforations you wanted to provide. So even in the most severe of cases, if we wanted to perforate 15 sites in each arch, a total of 30 micro-osteoperforations, we would be able to deliver it with a single device. So if we had a patient that required 2 episodes of micro-osteoperforation, we would end up with 2 devices. Most cases are treated with 1 to 2 rounds of micro-osteoperforation, and some of the severe cases will get a 3rd round. Okay, as time went by, all of a sudden we developed a disposable tip option that could be attached to a sterilizable handle. So now you have this textured grip of a handle that has an ability to spin in your palm, and you just rotate. So it's ergonomic, it's beautiful, it's a wonderful tool, fantastic, and I love it. And so what happens is you just buy the tips and you install the tip, you use it, and you dispose of it. Again, it has the retractable clear cover, so you can mark your depth and your gauge, and basically that is a wonderful, say, 2nd generation of tool. Now currently we have a contra-angle head, and the contra-angle head is a very nice advancement. You can see the difference in the straight angle. If we're trying to apply the micro-osteoperforation technique behind the canine, the access gets a little bit compromised. Now you have to stretch the cheek a little more. We have to position the jaw correctly to get access to, let's say, premolar, molar areas. So the first 2 generations had a little bit of an issue achieving micro-osteoperforations in the molar areas, whereas not that it was impossible, you just had to work a little harder at it. We still got them. But when we got to the contra angle, all of a sudden now you can reach posterior areas very simply. So it does have a 3-speed setting. The range goes up to 45 RPMs. It's a very simple function of turning it on and running it, and obviously it has reverse as well because you're going to go in and out of the bone. It's rechargeable, it's light, it's very simple to use. And that we would call today's, let's say, state-of-the-art appliance. Now there are benefits to micro-osteoperforations. So the patient, certainly it's minimally invasive. So micro-osteoperforation, we keep saying this word, or big long words, and what happens there is we are poking little holes. The reality is that considering the choices for accelerated orthodontic techniques, this is considered minimally invasive. The maxilla and the mandible have no innervation. So in the places we're perforating, we're not touching any nerves. So we just have to get past the soft tissue. So the reality for most patients is a very nice topical anesthetic is sufficient, and occasionally a drop of maybe a non-epinephrine carbocaine, but again a drop in an area to give them a little more comfort. But most patients deal with this in a manner that's not, there's no level of discomfort beyond using a topical anesthetic. It's a technique that's that is performed chairside, and it is minutes. Obviously, the first time you do anything, it takes an amount of time to feel comfortable, and you do a beautiful sequence of events to perform a nice technique. And the more you do it is a very quick learning curve. Once you've done a few of these micro-osteoperforations, you're an expert, really. And it's a very simple technique. It's done chairside. It is done in minutes. Even if an arch required a dozen or 15 micro-osteoperforations, it's all done in less than 5 minutes. From the point of topical application to the perforation of all of the sites. Less than 5 minutes is the typical time frame. And since most cases are going to be treated in 1 to 2 rounds of these micro-osteoperforations, it adds about 10 minutes to treatment time in the entirety of a case. You can use it obviously with aligners, with braces, with any type of orthodontic treatment. Whatever your orthodontic sequence is, you can incorporate a micro-osteoperforation technique. The design is to give you a half of your treatment time. Now, you can use it to treat the entire case. If you'd like to cut out, all of this time and reduce 50 to 60%, great, or you can go after one tooth. If there's a rate-limiting tooth or a tooth that's struggling or giving you difficulty or not keeping up, especially when we're talking about clear aligner therapy, you can go right after one tooth. So it is possible to use in an isolated and or comprehensive manner. It will certainly increase predictability. Anytime you're increasing the inflammatory markers and you're increasing the rate of bone remodeling and you're increasing your rate of tooth movement, you're really providing better orthodontic mobility. So all of the extra inflammatory markers can increase your tracking and or predictability that you'll be able to solve the case that you initially set out to do. There really is no patient recovery time. I would call the recovery time about 10 minutes, the time that you're in the office. The patients that we've treated all received Tylenol on the way out of our office at the time of treatment. So whenever we provided a patient with the micro-osteoperforation technique, they were given 2 Tylenol. And then they were instructed to see how they felt later. Now, the good news about using topical anesthetic or a non-epinephrine carbocaine is that it's going to wear off in 5 minutes. The patient's going to leave the office without any numbness there because we're only delivering, if we go to the carbocaine, we're only going to deliver a drop of it. And a drop of it won't last very long. So the patient will take the 2 Tylenol to their office. They'll tell you, yep, I noticed you did something. We call them that evening, we call them the next morning just to double check on them, but we haven't had patients taking Tylenol beyond the first day. So usually they take it at our office and they take the 2 Tylenol at night. We do encourage them to take 2 for bedtime. So they take another dose of the Tylenol at night. Most have reported they didn't feel like they needed it. The soreness level in the evening, by the evening, was very little to none. We encourage them to take it to make sure we fulfill the full night's sleep. And the next morning, we would call to check and see, how are you doing? Do you require a Tylenol today? And the answer was always no. So we haven't had anybody really take the Tylenol on the second day. So now, you don't have to worry about patient compliance. When you're delivering a micro-osteoperforation technique, you're delivering a way to reduce your treatment time without having any involvement of the patient, no compliance whatsoever. It can be done during a standard orthodontic visit in your practice within minutes. So you're going to save a lot of time for you and the patient. The patient is going to benefit from half that treatment time because they're also going to enjoy that shorter treatment time, which means less trips to your office. Since we're talking about adults, 17 and above, let's say, we're talking about high school to college and beyond in the workforce. Patients in those age groups are going to look forward to, basically look forward to visiting you less. All right, the practice benefits. Well, you're providing cutting-edge technology. You can certainly increase treatment acceptance because whenever you're talking about orthodontics, there may be a, let's say, percentage of patients that can't commit to 12 months, 14 months, 16 months, 18 months of treatment. But all of a sudden, if you can take those cases and reduce them to 6, 8, and 10 months, you have an opportunity to offer half of the time for treatment. Patients will be saying yes to that versus the entire full time it would take without a micro-osteoperforation technique. Certainly, it can attract new patients. This has been a big cheerleader in our office because now your patient who's in braces or Invisalign or some sort of clear aligner therapy, what they're going to do is they're going to talk to their friends, neighbors, family members about how much quicker their treatment is going and how comfortable they feel, and they won't have to be in their aligners and or braces for as long. So you really have a fantastic opportunity to reduce the treatment time, which has an effect on compliance. If you're dealing with clear aligner patients and you have to treat a case for 12 to 14 months, yeah, the patients are excited at the beginning, but if you've done clear aligner therapy for a while, you realize the last few months of treatment, sometimes they start fading, and they're looking to be done. Well, if all of a sudden that 12-month case is taking 6, or the 14-month case is taking 7 months, all of a sudden you're past their fatigue point. So you have someone who can get all of the compliance in for you, and you'll have better tracking, less refinements, and less case follow-up. All right, so now let's talk about the micro-osteoperforation technique. Very simple. So first, you're going to be evaluating where you'll be performing these. So look, you can palpate the tissue, you can look at the teeth all you want. The x-rays are probably going to be your best source. And the idea behind the micro-osteoperforation technique is that the cutting instrument is the same width or diameter as a TAD, a temporary anchorage device. The mini implants that are used in orthodontics for anchorage, for the absolute anchorage, so to speak, are 1.6 millimeters in diameter, and that's the same diameter of our cutting edge. So the idea here is any place that you can put a TAD, you can perform a micro-osteoperforation technique. So when you're looking at your x-rays, you'll start seeing the space that's available in between the roots. And the yellow dots on the screen show where we have potential sites for micro-osteoperforation. And certainly, you're looking to avoid the roots of the teeth. You're looking to avoid the nerve trunk. You're looking to avoid the vascular areas. And you're looking to avoid sinuses and the upper arch. So the idea is you have plenty of opportunity to study the x-rays and avoid the crowded or overlapped teeth or roots and go to the areas that are available for you. So once you've studied the x-rays, you'll know, okay, where can I place a TAD, or where can I perform a micro-osteoperforation technique? And you can either make yourself a list or a chart or keep your x-rays up and available while you're doing the procedure. It all starts with a rinse. So every patient gets the chlorhexidine or Peridex rinse, and we do perform 2 one-minute rinses. So 2 cups are set out with a nice amount to rinse with. The patient takes it, they squish, and they rinse for 1 minute, and then they expectorate, and then we repeat it. So the patient is going to perform 2 one-minute rinses for you prior to beginning the micro-osteoperforation technique. And then it's anesthetize and accelerate. So now, topical anesthetic is the key. Every patient needs a little topical anesthetic, and some patients need a little more than topical anesthetic. And the point behind having a local infiltrate is not to use the epinephrine. It's not necessary. This does not generate a significant bleed, so you're not worried about controlling blood. And you're also not looking to numb the teeth. So when we're going to, let's say, take on that patient who's a little more sensitive than others, and we all have our share of patients that are different levels of sensitivity. Topical anesthetic is one thing. There's your easiest case. When you have a patient who's going to respond a little more, you might want to put a drop of a carbocaine. So I use a non-epinephrine carbocaine, and when I say 1 drop, I mean 1 drop. If I'm going to do a Propel site right here where this Explorer is, I'll put my topical anesthetic. If I feel like the patient doesn't like the sensation of the pressure from the probe, then I'm going to take my carbocaine in my syringe, and I'm going to go right to that same spot, and I will add 1 drop of the carbocaine here, and then go right ahead and Propel that site. So a drop of carbocaine is wonderful because it's really just controlling the tissue response. The bone won't have a response to the micro-osteoperforation. So now, the depths that we're going. Obviously, once we have our topical and or our drop of carbocaine, we're ready to perform our technique, and the depth is determined by the thickness of the bone. So we do have to break the cortical bone. So we've got to get through that cortical bone. We have to get past it, which means we have to get to a certain thickness and through the tissue and through that bone. So we're going to show you a chart in a minute that'll give you those depths. But the idea is anywhere from 2 millimeters to, let's say, 7 millimeters is the depth. I would tell you most of my cases are treated between 3 and 4 millimeters of depth. And we'll show you those charts as we get to them. Okay, so most patients require 1 to 2 treatments. A complex case might get to 3. If we have to set up a basic chart, we would say a mild orthodontic case or condition would require 1 treatment. A moderate orthodontic case or treatment or condition might require 2 micro-osteoperforation techniques separated by about 12 weeks. And a complex orthodontic case might require 3 micro-osteoperforation techniques, 1 at the beginning of treatment, the second one to be 12 weeks later, and the third one to be 12 weeks later. Now, when we are perforating, we're taking advantage of the space between the roots. So basically, you're looking to deliver as many micro-osteoperforation sites as you can. Some interproximal sites will allow 1, some will allow 3. They can be in a straight line, they can be in a triangle formation. Anything that the site allows is terrific. Now, the osteoclast response will be measured anywhere from 6 to 10 millimeters. So when you're performing, let's say, micro-osteoperforation between teeth 5 and 6, we'll go with the upper right quadrant. 5 and 6 is our premolar and canine site. If we performed micro-osteoperforation there, 6 to 10 millimeters is 1 to 2 teeth, or mesial and distal. So you have a response that's registered past the one single tooth. The good news about that 6 to 10 millimeter range is that you do not need to put a perforation between every single root. Most of the cases we're treating, because obviously we're performing orthodontics, there's crowding and overlap and roots that are too close in proximity to get that 1.6 millimeter diameter between. So we're not interested in perforating between every single tooth, even if we can get every other or every second or third tooth involved with the perforation, we're going to be just fine. So now, certainly you'll go after the more complicated teeth. When you have teeth that have more time to take, when you're going to take more time getting a particular tooth or teeth to place, you're going to basically concentrate on those and make sure that they keep up with the case and or track nicely and or reduce their treatment time. So the rate limiting teeth are the ones to focus on. I tend to use the micro-osteoperforation technique as a comprehensive technique where I just treat the whole arch. I go from basically molar to molar and I spread my perforations out because I'd like to accelerate the entire process and not just focus on one difficult tooth or 2 difficult teeth. Again, the depth selection, you can go anywhere from 3 to 5 to 7. If you had to give the rough thing, the lower anteriors can even be 2 millimeters and near enough, but 3 millimeters of the anterior and somewhere in the posterior 5 to 7, palate 7 millimeters depth, those are available depths. Most of the depths I've worked at is between 2 and 4 millimeters. Now, the osteoclastic defect, it peaks at 24 hours. So that 24 hours is your peak of your inflammatory response, but it does remain for 10 to 12 weeks. And 10 to 12 weeks is a time frame that's incredible because normally bone will heal in about 6 to 8 weeks, but we have a pressure that we're keeping on the teeth. So we're not allowing the bone to heal because we're constantly moving it. So the pressure on the teeth extends the healing time. Normal healing time being 6 to 8 weeks. A micro-osteoperforation technique with orthodontics involved in the case will take a 10 to 12 week process to get that healed, and then you'll repeat your process. Now, if we were using the single-use device, you would set your depth. It comes in the odd numbers, so it would be used at 3 or 5 or 7 millimeters. And you're rotating clockwise. It's similar to working with a screwdriver. If you'd like to place the screw, you're going clockwise. If you want to remove the screw, you're counterclockwise. So you would place your device perpendicular to the alveolus in between the roots. You would apply your pressure and twist clockwise until the device illuminated, and then you would have your depth. You would rotate counterclockwise to remove. So it's basically in and out, and now you've made a single micro-osteoperforation, and then it's repeat as necessary. The reusable handle, okay, you can take your tip of choice. There are tips that have covered sleeves, the protective clear sleeve, and then those that don't. So now when you press and release the ring, it lets you attach the driver, and then you can do the same technique, rotating clockwise with gentle pressure, and then you can achieve your depth with the depth gauge on the clear marker has the markings for the 3, 5, and 7 millimeter depth. Once you achieve your depth, you come back counterclockwise. The tip gets disengaged when you've provided all of the micro-osteoperforations that you need for that patient's treatment, and that tip gets discarded and sharps. The handle gets sterilized for the next patient. All right, so now the power driver, which is a little newer, needs to be charged, so you're going to charge it. Obviously, you're going to secure the tip in the contra angle head, so you'll be purchasing the tips, okay? And so once you have that in, now you're ready, and you press and hold the power button to turn it on. Select the RPM. The recommended setting is high, which is the 45 RPM. Now, you'll select your torque, okay? The recommended setting is 15 Newton centimeters. You can increase your torque setting as required to reach a desired perforation depth. If you would like to go a little deeper, you raise the torque setting a slight amount. You'll position that contra angle by depressing the black collar for best access. Okay, here's your black collar right here. When you have confirmed that the tip is 90 degrees to the point of contact, now you can start, and you'll depress the start and stop button, which is right here below the black collar. Okay, so now when you've set your depth and you have your desired depth, you hit reverse. You're going to hit stop, you're going to hit reverse, and then this will then counterclockwise spin until you're out. And once you're out, then you can hit the stop button again, and then repeat as necessary. So it's start it, achieve your depth, stop it, reverse, and then start it again to reverse. So you activate it to go forward, you stop it, then you activate it to go backwards, and you stop it. Then you can dispose the tip when you're done with it. The same tip can be used on all of the micro-osteoperforations for the patient. So if the patient requires 15 in each arch, you can go through all 30 of them with the same tip and then dispose of it, and you'll use a new one on the next patient. And the next time you see a patient, next time you see that patient, you'll get a new one. All right, where to perforate? Most of the time I'm doing the micro-osteoperforations throughout the buccal areas. Only rarely do I find a need to go to the lingual. If you were working on a case like this where you have these lingually impacted canines, you might want to micro-osteoperforate around those as best you can. So you do have the buccal access being the easiest of all areas. The palatal aspect gives you some opportunity. And again, we're just looking for structures to avoid, certainly the roots, nerves, vascular sites, and sinuses. This is what it would look like to have a couple lined up. You'd have one here and one here. Again, one here and one here. You could have two in a row between these teeth. If you have a wider space between the roots, you can make a triangle out of them. That's fine. You can perforate here where it's a little narrower. Where it widens, you can get two. Here, if you don't have the wide space, you can do three in a row. So the general rule of thumb is just, take what it'll give you. There's plenty of opportunity throughout an arch to get to 10 or 12 sites if you're doing a very involved case. Mild cases require less than that. So you should never be short on opportunities to use this device. How deep? It's a general chart, 3 millimeters for anterior teeth, 5 millimeters for posterior. My experience is 2 to 4. I don't really use 5 millimeters very much, but it's available to you. You certainly can. The temporary anchorage devices that are placed go in anywhere from 5 to 8 millimeters, so you have an opportunity to give yourself some good depth without hitting any of the structures. One of the reasons that we don't do the full anesthesia mode, meaning numb the entire arch or numb a quadrant or do a block, is because you do want those teeth vital so that while you're performing your technique, if you happen to get within a millimeter of the PDL, the patient will let you know that they're starting to feel an increase in pressure. It's a good indicator to back off. So if you numb the whole tooth, if you numb the area within a block of some sort and the teeth can't respond, now you have an opportunity to touch a tooth and not know it. So much better off keeping a drop of anesthetic nearby, make your perforation. If the patient responds with a little extra pressure that they're feeling, you can back right out. So again, the technique, it can be whatever the teeth, the bone, the distance between them affords you. If it's one site, great. If it's two, terrific. If it's three, home run. If it's a triangle, that's fine. Obviously, when we're doing orthodontics, we have teeth and roots that are all over the place, so you go through your x-rays to determine where and how many of these sites you can make, and you draw a little map. Now, for the patient receiving the treatment, if we place some topical and make our perforations in both arches, they're going to be given 2 Tylenol at the end of our session. So they'll have taken 2 Tylenol at the office. We recommend that they take 2 Tylenol for bedtime, and we haven't had anybody really need to take Tylenol the following day. The important part of taking Tylenol is to follow it with the next instruction, which is avoid taking the anti-inflammatories. So we're trying to avoid the Motrins, the Advils, the Aleve, the ibuprofens, because anything that's anti-inflammatory is in effect reducing the response that you just generated. So we're producing an inflammatory response, we're elevating it on purpose. We would like all of the inflammatory markers to linger as much as possible, so taking a dose of anti-inflammatory medication is trouble because it's counterproductive to our technique. So we give the patient the Tylenol, and we recommend that they do not take their Motrins and Aleves and Advils and ibuprofens really at any time during the orthodontic process. What can we use it for? Well, anything. Now, if you're diagnosing an orthodontic need and making a recommendation for the patient to have any type of orthodontics, well, the list is on the screen and it's not even comprehensive, but anything that's involved in orthodontics, whether it's crowding or spacing, molar uprighting, mesialization, protraction, distalization, if you're doing pre-prosthetic orthodontics, rotations, impactions, extrusions, intrusions, pre-implant therapy, congenitally missing teeth, midline discrepancies, open bites, deep bites, class 2s, class 3s, any orthodontic condition, any orthodontic malocclusion, anything that you're doing that would help a patient to achieve a healthy and stable and beautiful and functional smile and bite can be sped up, so to speak. So you can have an accelerated technique with any type of orthodontic process. So we'll focus on aligners. Since the past 5.5 years, my focus has been using clear aligner therapy for treating. I'll share with you a few of the cases now. And we'll start out with some of the mild cases, and we'll advance to maybe a little moderate for this evening's presentation. So this case is courtesy of Dr. Thomas Shipley, who has been publishing some of these nicely. So if you're aware of his work, it's probably because you've read it already in a journal. And Dr. Thomas Shipley does some very nice accelerated orthodontic technique. This happens to be clear aligner therapy with micro-osteoperforation. But this case here, if you have some experience with clear aligners, you would recognize that a fair treatment time with clear aligners would take about 14 aligners, and 14 aligners is 7 months because we wear 2 per month. So every 2 weeks we're changing the aligner, so 14 aligners would be about 7 months. But with this clear aligner therapy and using one micro-osteoperforation application at the beginning, this case was treated in 8 weeks. And so in 8 weeks' time, we can have this. And so 8 weeks later, we have very nice straight teeth here and a beautiful result. And we've got a happy patient that now has their teeth aligned, which is probably what their chief complaint was. 8 weeks is only 2 months. So we go from 7 months to 2 months. In a mild case where we're dealing with one micro-osteoperforation, the reduction of the wear time can be all the way down to somewhere between 3 to 5 days. So you're cutting out 2/3 of the time here. Instead of 7 months, you're doing this in 2 months. Taking out 2/3 of the time, a good 60 to 70% reduction in time can make this a very quick and comfortable and really easy case for a patient to handle. Another case by Dr. Thomas Shipley is treated with clear aligners and one micro-osteoperforation technique. And the idea here is these before photographs show a little bit of crowding, a slightly deep bite. And if we were treating this with a clear aligner therapy, this is something that would probably take about 10 months. 10 months is a fair estimate for treatment time for a case like this, but including one micro-osteoperforation at the beginning of treatment, this case is reduced to a 3-month treatment time. And in those 3 months, Dr. Shipley is able to achieve this result, a correction of the crowding and the deep bite. So the patient has an improvement in their arch form and their arch width, and also in their overbite and overjet. They have their canine protection. It looks like nice posterior intercuspation without interference. So that's a wonderful service, and all taking place in 3 months. So the smaller or shorter or more mild the condition, the opportunity is greater to save more time. As we get to more of the severe cases, we'll show you how we end up at more of a 50% reduction in time versus this. This is taking out a good 2/3 of treatment here. Again, Dr. Thomas Shipley, another case with some class 1 malocclusion, some crowding of the lower anterior teeth, a little bit of the upper, and an expected treatment time to get this case completely resolved would be about 17 months, maybe 15 to 17 months realistically. And here you have, again, a case that's utilizing one micro-osteoperforation application at the beginning of treatment and followed by 6 months in Invisalign. So certainly a reduction of greater than 50% of the treatment time to deliver a change that'll get this patient here. And so now you have a beautiful overbite, overjet, looks like a canine protected occlusion, posterior intercuspation without interference, and of course everything's leveled and aligned. So yeah, you have a fantastic result, bound to have a happy patient and a comfortable patient having a nice arch form and a nice arch width and all of these good credentials that you'd like to see in a shorter amount of treatment time. Another case that involves only one application of the micro-osteoperforation technique at the beginning. So without micro-osteoperforation, that crossbite of the anterior teeth would take a little bit more. So you have, when you're looking at tooth number 10, it's involved in a crossbite with 22 and 23. This would take a little more time in clear aligners, but still very possible. It's a wonderful opportunity to give a patient a better occlusion. And if we were to estimate this at somewhere between 13, 14 months or a 27 aligner count, the actual treatment time for Dr. Shipley was 4 months using one micro-osteoperforation technique. So a case that would take a little over a year, just a touch over a year, could be treated by removing 2/3 of that treatment time and saving that patient 65% of their time, gets them down to 4 months. So this is a 4-month treatment to correct the anterior crossbite, which is a wonderful savings time for that patient and Dr. Shipley. So I'll introduce you to one of our early patients in the micro-osteoperforation technique. Dina was one of the first ones that we treated with the micro-osteoperforation technique and clear aligner therapy. So she came in with all the credentials of a malocclusion, some anterior crossbite. At a young age, she already shows the wear and tear on the teeth. We have all the craze lines, we have the chipping and the wear and the tear that is basically the result of having this poor occlusion for a couple of decades. And for someone who's in their mid-30s, they're having a little more wear and tear than we'd like to see on those teeth. We got a little crossbite of the front teeth. We certainly have our share of recession and abfraction, even though they're mild and at the beginning stages. These are something that are present because of the type of malocclusion our patient has. So we can see we have a fair amount of crowding or overlap of the teeth. The lower has a little bit more, so we might call this something like a mild or moderately crowded case. We have a retained primary tooth that has a beautiful amalgam restoration in. This patient, having held onto this tooth a couple of decades more than it should have lasted, is because there is no premolar underneath there. So basically that is our little space saver for a future implant. That's what we're looking at there. So the patient has a class 1 malocclusion on both sides, and that malocclusion has delivered some of the changes and or deteriorations we would expect to see from having the teeth occlude in a fashion like this. So we have all these little issues. But if we want to talk to Dina about clear aligner therapy, which is desirable for most adults, we would take a look at her x-rays, and starting with a Panorex, it's a wonderful place to start, but we could start to find wonderful access, and certainly underneath the retained primary tooth is a beautiful place to put some perforations right here. So we have terrific access between a lot of these roots. One of the things to consider would be whether or not the pan is diagnostic in all areas, and it's not. The reality is that a Panorex might give me some places clear, and it might give me some that I really can't tell. So we would never use a Panorex only. I would take PAs as well. So we would take individual PAs of any areas or any real patient that we're going to treat with micro-osteoperforations to make sure we have an opening or availability. I know I don't have to go after the tightest areas. I'm not interested in trying to sneak that 1.6 millimeter diameter into a 1.7 millimeter space. There's no reason to fight that much. I'm looking for big areas that I can go after because I know there'll be plenty of opportunity to deliver enough. Now, if we're talking about clear aligners, we may as well take a quick look at what a ClinCheck would look like, just so we can see what movement is desired for this case. So when we open up this ClinCheck, it gives us an opportunity to see, obviously we know where she's starting, but where she's going to finish. How far are we looking to get with this type of malocclusion? Are we looking to solve the entire thing for our patient? Generally, the answer is yes, but we'll take a look at a couple of views. The maxillary view for starters. So let's take a look at and press play here. And we'll watch the 21 aligners go by. 24 is the full count using what Invisalign calls a virtual C chain at the end of treatment. But with this case, we're going to probably use 24 aligners, maybe 23, to make sure that at the end of the case we have tight flossing contacts everywhere. And that's a nice desirable change. The lower teeth, we've got a little IPR over here. Not afraid to have a little IPR, especially by a retained primary tooth, because we know one day if that primary tooth is lost, which it's not likely to last that patient's lifetime, we wouldn't mind having a better space set up for an implant. So I'd love to take 1.5 millimeters off of the mesial of that tooth and leave behind a little less tooth structure in there and take advantage of that and get rid of my crowding. So we have a nice change here. The anterior view is going to show us what's going to happen here. So we have all of the movements we'd like to see to generate an overbite and overjet, a canine guided or protected occlusion with posterior intercuspation without interference. We'd like to deliver some credentials that give the patient a good occlusion. And so we're starting out with a malocclusion, with a crossbite and some edge-to-edge, and certainly an irregular gum line, and we'd love to get that organized, leveled and aligned, expanded and rotated so that we can have all of these teeth come together nicely. So obviously what's going to happen is we're going to put our first aligner on, we're going to get our attachments in place, we're going to put aligners in there, and we're going to then deliver our micro-osteoperforation technique. So I was using the forms that came with the clear aligner case where we would have these kind of pictorials of where the attachments are. What I would do is go to my x-rays and I'd start to use red dots to denote, okay, where can I perforate? And I would highlight on my paper here what areas are available to me. And certainly the dots that are closest to the crown are more incisively located, and then the second row is more gingivally or mid-root. The teeth getting narrower give us more access as we go farther apically. So here you could see altogether what I was able to do on the upper was 12 micro-osteoperforation sites, and on the lower 12 micro-osteoperforation sites. This is one of the original notes that we would make at that visit. 2 Tylenol were delivered at that visit. And it looks like this. This is what it looks like the minute after we deliver a dozen micro-osteoperforation sites to the patient. So several of them are identifiable, and some of them you don't see, but they're very tiny. So when we get these little things done, that little drop of blood goes away within the first real minute or two. Now, in a case like this that has 24 aligners, we're going to go and spend a year. 12 months would be the treatment time. What we did for Dina was, after the first 12 weeks went by, we would deliver a second round of micro-osteoperforation. Considering her malocclusion isn't really in the mild category, we're going to consider it a moderate type of malocclusion. I would go ahead with 2 micro-osteoperforation techniques, one at the beginning and then one about 10 to 12 weeks later is an acceptable time frame. Because the first 12 weeks resolve a lot of issues, we now have a less complicated case. So with every stage you pass in your orthodontic technique, you have a less complicated case. Because you have a less complicated case, you don't need the same number of micro-osteoperforations. So we go from a beginning, maybe a moderate case. After 12 weeks, we've now got a mild case. So I do less micro-osteoperforation in the second round. There's only 4 sites and 4 sites being done. So a total of 8. So in our second phase, we do a little less. Cases that are severe that get a third phase, they get even less during that one. But in the end, as one of the early days or early cases in the clinical trials with the micro-osteoperforations, what we did was we took her 24 aligners and we delivered her case in a 10 to 11 day change. So she was wearing her aligners at 10 to 11 days, and throughout the case, wearing them 10 to 11 delivered her occlusion on the right side and on the left side. Now what's happened here is a significant change in our occlusion over here makes a significant response in the gingival tissue. So by expanding and uprighting all of these teeth, we get a favorable change in what was a V or notched or beginning of a cleft in the perio to now the reshaping and a dome forming around those teeth. So we're getting an improvement there. We're also taking care of what was a crossbite and a lack of a canine guided or protected occlusion and delivering a canine guided or protected occlusion on her left side. So it's a nice change from what is a malocclusion to a healthy, stable, functional occlusion. Undoing the crowding obviously is very nice. We want to level and align all the teeth. We'd like to have a wide arch form. We'd like to have a nice shape to it, and it should be reflected in the lower teeth as well. In this case, providing all of those micro-osteoperforations, we did a slight advantage in that that primary tooth was not ankylosed. Because of the fact that that primary tooth was not ankylosed, I was able to expand it. So we have a wider distance, and uprighting that tooth keeps it lined up with the other teeth. So now we have a case where we have all of these teeth unraveled and we have a beautiful occlusion. Having the beautiful occlusion gives you the level and even gum tissue. So now we have a case that has a respectable overbite overjet canine guided or protected component, as well as posterior intercuspation without interference. In the clear aligners, you put a little bleach gel, takes the shade off the teeth, so you have a patient who's very happy on so many levels. We've taken what was a malocclusion and converted it into a very nice occlusion. This case does not require any refinement. That case is corrected in just the 24 aligners, and that took 9 months. So instead of 12 months, 9 months. We were able to take 25% off that treatment time, and as an earlier case, we had the opportunity to reduce her treatment time by about 3 months, and this case was treated in 9 months without a refinement. That type of malocclusion without the micro-osteoperforation technique would not only take the 12 months, but I would typically get 4 to 6 refinement aligners. So my history with clear aligner therapy is about 13 years now, almost 1,000 cases, and I would comfortably treat that case on a standard path of about 15 months and deliver a similar photograph. But to be able to do it in 9 is a huge advantage, and only having 1 set of clear aligners, not needing a refinement session to get there. So you have a patient who's happy, and the entire treatment time is 9 months versus 12 to 15. If it had gone perfectly in 12 months, we would have a 25% reduction in treatment time there. All right, so a second case is our patient Veronique, and she is French-Canadian. So she's in our office asking for Invisalign to correct her smile because she does have 1 tooth kind of tucked behind there. Tooth number 10 is a little bit off, and she's a young, attractive girl, but she just didn't want to wear the braces. She was uncomfortable and self-conscious about running around with braces on in her 20s. So, you know, we would agree we're happy to help you there. So we've got tooth number 10 in crossbite back there. We've got the lower right side in crossbite with the upper right side. So every bit of a malocclusion, however you'd like to diagnose and categorize, the midline being off, a poor overbite overjet relationship, terrible anterior and posterior crossbite, and already the consequence of the malocclusion, because if you're already about, let's say, 25 or 26 years old, you've got a solid decade and a half using the teeth in this type of arrangement, and you can see she is already having some signs of recession. So having the recession and having the so-called deterioration factor at a young age is a good reason, not just for the cosmetics, to treat this case. So we can look at the arch form, and we can look at the arch width, and we can look at, you know, all of these teeth being malpositioned on some level and decide that, oh, she's a wonderful candidate for orthodontics, and certainly we would diagnose decay, and that would get taken care of as well. So if you find any decay, you get to do a little more if you're the GP. If not, you get a nice referral to one to do that too. So here we've got a malocclusion from whatever diagnostic standpoint you'd like to make of it. You've got a patient who's ready, willing, and eager to perform some orthodontics, and she's going to be interested in more of a clear aligner approach. That's fine. Here are some PAs of her case. A Panorex wasn't clear enough. We start taking PAs and we find wonderful opportunity. Look at the room between these teeth. Excellent opportunity. This is a site where you can do 1, 2, 3, 2 over here, 2 over here, even 3. You can get a lot of micro-osteoperforations done in these areas here. So we're not going to go too far back because of the sinus. You can get 1 over here. You can put 2 or 3 right here. Certainly we can look at the lateral being tucked back. You have opportunity to work in there. You can get a couple over here. There will be access for you. Just take advantage of all of the opportunities that you have to deliver a technique that can help her get her teeth in place faster. So obviously she's going to be interested in acceleration. Most of the patients that we talk to about clear aligner therapy are excited to have it. It's kind, it's gentle, it's comfortable, all those good things. But then when you can do it in a reduced amount of time, well, there's a bigger benefit. So here we have a nice representation of where she is. We'll press play and give you an idea of what the 23 aligners are going to look like. So we're going to have 23 aligners to get that change from here to here. We're looking at some reasonable kind of expanding and shaping of the arch. So we're going to do that for her. Then we're going to take the lower and press play and get that organized with a little bit of expanding and shaping, not as much expanding because the lower's got a little crossbite activity going on. So we have more expanding of the upper arch to get itself outside of the lower arch. And if we take a look at the anterior picture, we'll go right ahead and press play and watch what happens to the anterior. We're going to expect some midline shift there for her to welcome tooth number 10 to the party. And certainly by the time we're done, we should have solved a lot of that malocclusion for her. So it's a little more complicated malocclusion. It starts involving molar crossbites. It starts involving anterior crossbites. It starts having some components of recession and abfraction present. She does have her wisdom teeth there, so we had to make sure we captured them in the impression, or at least half of them, to be able to prevent them from super erupting during the case. So now we'd like to see how that tracks and follows. So let's go ahead and take a look at some photographs and see what we were able to offer Veronique. So the first micro-osteoperforation technique at the beginning of the case involved all these red dots. So if you take a look here, you've got 2, 4, 5, 6, 7, 8, 9. So I did 9 perforations, and by this time when we were treating the cases, I was being a little more sophisticated, and I drew 3 bars across here. These 3 rows that you see are basically to show the thirds of the root. And so in the thirds of the root, I was deciding, okay, the coronal third of the root versus the middle third versus the apical third. You know, where did I have opportunity? So I started giving myself some so-called depth to give me an idea of where I could place my micro-osteoperforations. The depth chart will show you they were all 3 to 4 millimeters deep. The lower we did 2, 4, 5, 6, 7, 8, 9, 10. 10 perforations on the lower, 9 on the upper, 19 total for the first round. Then we get to aligner 14. And so she's going to be wearing these aligners at about a 10-day change, again, early in the treatment. So 10 out of 14, you're taking away about a third of the treatment time. And so what we're looking at here is a 14. And here's the 14 aligner in the upper arch. So we've got a little bit of movement happening. And by the time we get to aligner 14, we're ready for a second perforation. And so having a moderate case will offer that to the upper teeth here. So we have 3 and 3. We have 6 micro-osteoperforations of about 3 to 4 millimeters in depth. The lower arch required less treatment. It doesn't require the extra micro-osteoperforations. By the time we get to aligner 14, the lower arch is almost done. The upper arch was what really took the 23 aligners to get there. So by the time we finished this case, there was a refinement needed. So we ended up needing 2 refinements to finish correcting this. And the grand total of treatment was 40 aligners. So I did use 40 aligners to treat this case to get to this arch form and arch width. But in those 40 aligners, the treatment time was 12 months. So what started out being a 10-day change for the first third of treatment, once I was comfortable with that, I moved to then 9 days, then 8 days. So as the years were going by, we were starting to reduce the treatment time, the wear time on the aligners for this patient, as well as others, to figure out, well, how low can we go? And the idea was we started figuring out the time frame, the number of osteoperforations, and the number of rounds they would need to deliver an amount of wear time, so to speak, for the aligner. So we managed to get her to here, and although it took 40 aligners, a typical time for 40 aligners is about 18 to 19 months. And 18 to 19 months became 12 months. So we were able to take off a good 30 to 40% of treatment time and deliver a very nice occlusion for her that she's happy with, that resolves all of the crossbite issues and certainly sets her up to have success going forward. The midline is recovered mostly, and we have a patient that's going to be pretty happy with that. Now the chart I was referencing at the beginning is a summary of where we are, and the cases I introduced you to were mild to moderate. So we're introducing mild to moderate. Again, this is a 3-part series, so we have 2 more parts coming up, and I believe the next one is going to be in September, where we'll start introducing the more moderate to severe type of orthodontic conditions and go from there. So we'll be building on this series with more complicated orthodontic treatment. But this chart I put together, it's my own chart to give you an idea of what I have come up with over the last 5.5 years. So if you look at on top, the blue section on top is the rounds of micro-osteoperforation. So MOP is micro-osteoperforation, MOP. So the first micro-osteoperforation round, the second round, and the third round. So if we look at the case type, what you would look at in this column going down here is whether or not you had a mild orthodontic condition, a moderate orthodontic, or a severe orthodontic condition. I tried to give a rough definition of that without getting too crazy. But mild, I would consider anything up to 9 months. Anything 9 months or below, you're talking about a mild condition, should be easy to resolve with 1 round of micro-osteoperforation at the beginning of treatment. And we saw with Dr. Shipley's cases, very possible to take things even closer to the 10 or 11, maybe 12-month mark and treat them with 1 micro-osteoperforation or 1 MOP at the beginning of case. A mild case that we're working on with 9 months or less in normal time, I would deliver 8 to 10 perforations per arch. I would look for 8 to 10 sites in the upper arch, 8 to 10 in the lower arch, and in a mild case, knowing what we know now after about 5.5 years of use, 5-day aligner wear time is appropriate. You can reduce the wear time from 14 days to 5 days. That takes off about 2/3 of the treatment time. So a 9-month case could be done in 3 months, 4 at the most. Okay, now, when you get to a moderate orthodontic condition, maybe something that would take somewhere between 10 and 15 months to resolve, typically, that type of time frame I would like to use the micro-osteoperforation technique twice, once at the beginning, and the second one would be 10 to 12 weeks later. So at the 10 to 12 week mark, we would do it again. Now, as we're treating the case, the first micro-osteoperforation would involve 10 to 12 MOPs per arch, or 10 to 12 perforations per arch. And that would allow me to feel very comfortable with a 7-day aligner change. So a moderate case that's going to take me 10 to 15 months traditionally, I would do 10 to 12 micro-osteoperforations per arch and have the patient wear their aligners at 1-week intervals. But at 10 to 12 weeks into treatment, I would want to deliver a second round. And I would cut that in half. If I did 10 to 12, I'd probably do 4 to 6 micro-osteoperforations per arch. But we would continue with 7-day aligner changes. So that 10 to 15-month case could be treated in half the time. When we get to severe orthodontic conditions, something that might take 16 or more months, 16 to 24 months we'll talk about, in that time frame, I would probably want to deliver 3 rounds of micro-osteoperforation. I would go from round 1 to round 2 to round 3, and they would be 10 to 12 weeks apart. The first round is always at the beginning of the case. I would like to deliver more. Now, the more severe the orthodontic condition, the longer it's going to take to treat, the more I would like to enhance my cytokine production or my inflammatory response to get better bone remodeling and better tooth movement. So I would be looking for at minimum a dozen to up to 18 micro-osteoperforation sites per arch. So if we can get a dozen to 18 in each arch, we're going to deliver a wonderful inflammatory response and be able to use anywhere from a 9-day change down to 7 depending upon the case. One of the factors involved with clear aligner therapy that you always have to keep in mind is the compliance of the patient. We're assuming that at our 5-day or 7-day or 9-day changes we have wonderful compliance, which means they're delivering their 22 hours a day. If your patient doesn't deliver the time, that's where you might see the course run off a little bit, and maybe you're going to do a little refinement. But again, the 9-day aligner change is based on excellent compliance. If we have a severe orthodontic condition that we're going to tackle and normally would take anywhere from 16 to 24 months, that first round of 12 to 18 micro-osteoperforations delivering 9-day aligner changes will be followed 10 to 12 weeks later with a pretty significant round, 10 to 12. I still like to treat a severe case 12 weeks later with another good round of micro-osteoperforation. So I love to get another 10 to 12 sites per arch to keep my 9 days rolling. Certainly a third round is in order for more severe cases. It's more rare. A lot of orthodontics can be done in less than 16 months. So I think you could appreciate 16 months or less would accommodate most of the things we're doing, and then above 16 months I would go to a third round, and that third round would be done again 10 to 12 weeks after the second round, which was 10 to 12 weeks after the first round. By that point in time I would deliver 6 to 10 micro-osteoperforations per arch. I would continue my 9-day change. So this is I would call it a conservative chart, and so when you're looking at 5-day aligner changes, I know I have seen the cases and the publications where the doctors have used them at 3 and 4 days. I also know the moderate cases that are being treated at 7-day intervals can be treated at 6 or 5, and even the severe cases that are being changed out every 9 days can be done at 8 or 7. So what I've tried to do in this chart is give you something that is considered, or I would describe as a conservative time savings approach with this chart. So I'll leave that chart up for a little bit just to give you an idea of where we are, where I am after 5.5 years of treating clear aligner cases with the micro-osteoperforation technique. And I would call this a comfortable and conservative chart, but by no means is this carved in stone. This is not carved in stone. This is my own chart that I built for you based on my experience. I would recommend, experimenting a little bit and testing your own limits and cases on your patients individually, because there are patients who wear their aligners 24 hours a day, then there are those who wear them 18. There are patients who respond a little bit differently, and you would want to evaluate as time goes by. We have a flexible system here. I may take a severe case and start them at 9-day changes, and if I love the tracking after, let's say, 5 or 10 aligners, and I know I've got 30 aligners or 40 aligners to go through, I may reduce them to 8, 7, 6. We may make the changes during the case. So it's very possible to have a case start out with 9-day changes, and within the first few months go to 8, and then go to 7, go to 6. We'll work our way down, and at the moment I see a tiny tracking issue, I'll go back up by 1 day or 2 days. It's no problem to take someone from 7 days to 8 or from 8 to 9. You can walk your way up and down as you're monitoring the case. So certainly think of this chart as kind of conservative and also flexible. But in my experience, this is a fairly accurate representation of what I would deliver to achieve some very nice success using the micro-osteoperforation technique. Now I know it is about 4 minutes after 9. This was designed to be a 1 hour and a 1 hour session with some questions. So what I'm going to do now is open up a few questions here so I can answer and see what we have from some of our doctors. So I know some of the questions are typed in here. Let's get some of them open. We'll go through a few questions tonight. And then also we always have the opportunity to have questions answered at a later date. So the first question, what topical blend are you using? Where do you order it from? The good news is I never really used a blend. I know it exists. Certainly you can get the blend. I just used I believe it's the 20% benzocaine that's sitting on my counter that I would use for my traditional pre-anesthetic topical for crown and bridge and restorative dentistry. So I am only using a traditional, I believe, 20% benzocaine to paint on the surface. Now, the second question says, how many days per aligner in mild to moderate crowding? So mild to moderate, if we go back to my chart here, if we were looking at a mild to moderate case, mild to moderate, anywhere from 5 to 7 day changes is wonderful, providing you're doing the MOPS. In other words, just because you have a mild case doesn't mean you can go to 5 days. You have to deliver some sort of perforation. So 2 perforations or 3 perforations wouldn't be enough. Moderate, make sure you're getting 10 to 12 MOPS per arch to be able to deliver all of the movement, especially if your orthodontic technique is to move all 28 teeth. So the 2 cases I showed were representative of a typical Invisalign case where I want to move all of the teeth, including the molars, and get everything satisfied. So I don't do a lot of just anterior orthodontics. So the idea is, if we're going to be doing a mild to moderate case, I would expect easily to have a 7-day aligner change if you're delivering in a first round maybe 10 to 12 MOPS per arch and a second round of 4 to 6. So yes, the aligner change, the day change, is dependent upon how many MOPS you're delivering, because that creates the amount of inflammation and or cytokine level to be able to give you your resulting time change. Okay. Now, the next question shows up similar. How many days per aligner in a mild to moderate crowding? Well, I think we just answered that. The how many days per aligner in a moderate to severe? So these are good questions, and they're right on the chart. I think these questions were typed in before this chart popped up. So I hope I'm giving you enough time to maybe record this chart, write it down. I know this is being recorded. You'll have access to this chart after the fact. This should be an archived webinar at some point where you'll be able to look it back up, but you may as well jot down these time frames here to give yourself an idea of what the credentials are for delivering a technique that you can then produce the time change in your aligner. Okay. Then we have another question: can Propel be used to prevent posterior open bite in clear aligner cases? It's not necessarily that providing an accelerated orthodontic technique reduces your potential for posterior open bite in clear aligner cases. There's a different cause for that. That really is an issue beyond what micro-osteoperforation and or accelerated orthodontic cases allow for. So the short answer would be no. Propel is not used to prevent posterior open bite because the 2 are unrelated. When you're providing an accelerated orthodontic technique, you're looking to treat your case in a shorter amount of time. Achieving a posterior open bite is usually some sort of flaw in the technique. So if the technique is not, let's say, perfect, you may run the risk of developing a posterior open bite, and you have to work on technique there versus working on whether it's an accelerated type of case. Okay, now let's see if there's another question that's not repetitive. Okay, how, where, and how long do you apply the topical? Well, I usually take the topical on a cotton swab and paint it on the surfaces and give it about a minute. Any more than a minute isn't going to add anything, so the topical can go right in there for about a minute. And then if the patient's comfortable with a little pressure from the probe, we'll begin. And if they're a little bit, let's say, sensitive, I would add my drop of carbocaine. Okay. Now, in a severe case, can aligner wear be reduced from 9 days as treatment progresses and severity is reduced? Yes. I think I was answering that question along the lines of presenting this chart. So I'm glad I put this chart together because it does give you the idea that I was describing as flexible. And the rate at which I change my aligners is based on 2 things. Number 1 being the tracking. And when you're observing beautiful tracking, then the second criteria would be patient comfort, because if you weren't using micro-osteoperforation technique, if you weren't using an accelerated orthodontic technique and you just started changing aligners at less days, you could be rest assured your patient's going to respond. They're going to feel more tight. So if you just started using less days when it was inappropriate, the pain level would go up, the discomfort would go up. So the idea there is, if you have a patient who's wearing them at 9-day intervals and you see incredible tracking and that patient's describing incredible comfort level to you, it's time to go to 8. And if you do 8 days for a few times, let's say 2 or 3 aligners, and you have the same response, meaning the tracking looks beautiful and the comfort level is similar, then what would happen is you'd go to 7. So we do work our way down. We start, in some cases we might use the first aligner or 2 at 10 days just to make sure we're good and up and running, move to 9, move to 8, move to 7. We can work our way down that list right away till we find a spot where the patient still has great tracking, but they start noticing that the pressure's going up a little bit. Okay? All right, so here we have, when I use Propel, I infiltrate with Xylocaine with epi, and some of my patients still feel discomfort. I understand how topical would prevent them from feeling pain. I want to start using topical, but I'm worried. Okay, well, I think what might happen there is maybe that's a good example of trying to use a formulated topical. And if you get a formulated topical, it can be a much stronger topical anesthetic. There's nothing wrong with that. Go to that next. And then the xylocaine with epi, I don't use that. I've never used the xylocaine with epi for numbing for the Propel technique. I'm using a carbocaine without the epi. So, and only a drop. And we're telling the patient they're going to feel me pushing on them, but the alveolus doesn't have the innervation. There is no innervation. The nerves run above the roots and into the roots of the teeth, but the alveolus bone, that alveolar bone itself, doesn't have innervation, so they shouldn't be feeling the pain, but a little pressure is a yes. So I think you have to kind of distinguish the more sensitive patients from the ones who are a little tougher and figure that out. All right. Let's see here. We have a couple other questions. How often do you see your patients when you mop them? Okay, so when I do micro-osteoperforate the patient, certainly I'm going to want to watch that case because I do want to observe the tracking and the comfort level. So if you're going to give out a traditional case of Invisalign would be maybe 3 aligners. So if you give out 3 aligners and then that patient would wear them at 2 weeks' time, you'd see them in 6 weeks. So 6 weeks is a nice interval. So what I would be doing is keeping the 6-week interval. So my second appointment would be come back in 6 weeks. But if we're going to change the aligners at, let's say, 7 days, let's say it's a 7-day aligner change, 6 weeks, they have to have 6 aligners, not 3. So I give out the number of aligners that makes the 6-week mark happen. So I do like the 6-week interval when I'm doing the micro-osteoperforation. And as you gain more experience and you get more comfortable, then we start to stretch it. So just because of my level of experience with clear aligner therapy, I tend to give out 4 to 5 aligners at a time, and that's using them at 2-week intervals. So I go 8 to 10 weeks as a standard, but if I'm going to go 8 to 10 weeks using the micro-osteoperforation, I might be giving out 8 to 10 aligners if they're 1-week changes. Now if they're 10-day changes, if you have a case that you want to do 10 days on, let's say you're beginning, you want to test the waters, you want to give a 10-day aligner out instead of 2 weeks, you don't want to push the limits, let's say. If you're going to give out a 10-day aligner and you want to cover 6 weeks, well, 6 times 7 is 42 days, so you might want to give out 4 or 5 aligners so that you can do a 10-day interval and have them back in 6 weeks. So think about the 6-week interval to get you there, okay? All right, so our time is coming to a close. I recognize there are a couple of questions that regard the comparison between micro-osteoperforation and also a vibration type of technique. And in the 1-hour session tonight, I don't have time to really go through that comparison. However, yes, vibration techniques exist, and we're going to try to cover some of that in the future episodes. So we do have a 3-part series coming up, and hopefully in the 2nd or 3rd session we'll start to cover a little bit about what vibration and how it might compare to the micro-osteoperforation technique. So I don't have that information prepared for you this evening. So on that note, I'd like to thank everyone for coming out tonight, sitting in on the webinar. And I appreciate all of your time. I know this will be recorded, so if there's anything you feel like you missed or didn't get a chance to jot down, I hope I left that last kind of chart up for a while for you. It will be a recorded webinar. You should be able to look this up at a later date, watch it again just to pull out any information you might have missed the first time. Again, it's the first part of a 3-part series. So being that it's the first part of a 3-part series, we look forward to catching up with you again in September and then I believe February, and we'll certainly make an announcement as to the kind of topics, but the general scheme of things is going to be that next 1-hour session we're going to get involved with the more moderate to severe cases. So today we introduced mild to moderate, and just touching on those 2 cases at the end, bringing it to a moderate orthodontic conditions. The next visit we're going to talk about more severe orthodontic conditions and how they might benefit from the MOP technique. Thanks again for your time and have a wonderful evening.